EV, it's all new. It's all very interesting, and I wanted to spend some time with you talking about my perspectives of not how to use the system per se, but perhaps why it's so important that we do this. If you look at this, and I have already told you it's all new, and asked you to vote, is the new implant the one on the left or the one on the right, I think you might have a difficult time with it. In fact, the subtlety in the difference is reflected by the intellect and the dedication to change that went into the system. Why we should do this is because there's significant data that says dental implants should be improved. Now, that's my responsibility as a clinician, it's your responsibility as a clinician, but it's also an industrial responsibility, and we have to applaud our colleagues in the industry. Tom Peters said, excellent firms don't believe in excellence, only constant improvement and constant change. So you saw earlier this wonderful schema from 1985 to the present where Astrotech has undergone this evolution of implants over and over again. And the point about EV is they really want things to be better. One of our residents currently, a very, very talented young man, has a better way of describing this, and his goal every day is to, as you can see, suck less every day, and he just wants to get incrementally better, and I think we all do, and EV sort of is a representation. Well, why? There's a need, and who? Well, look at these examples. Maybe the leadership or the employees of Astrotech don't like seeing this, but you know what? Implants do fail. Components do break. Sometimes they're misused. Oftentimes they're misused. Sometimes they're abused by patients. But the reality is, at the end of the day, it is not when, it is not where. For me, it's not how, and for sure, it's important why. But at the end of the day, it's always who. For whom did the failure occur, and how can I avoid this in the future? I've made a little chart here. And what we're looking at is, how long a prosthesis may last. And we have data that says complications with single teeth implants and components, they're very, very successful out at about 10 to 15 years. And if we look at a bell-shaped curve, all those people that are having 98 and 99% success at that 10 to 15-year time point are really very lucky. But what about these people? What about the people that are on the tail end of that curve and have had a failure at 2 years or 3 years or 4 years? And in our practices and in the world, those are hundreds of patients. And so if you walk around the industry and you ask your colleagues who are in this business and you say to them, what's your post-market survey data? Then they say, how do you know about the post-market survey data? Clark's smiling. Well, the reality is they keep track of their problems and their complications. And they'll be very honest with you. Well, this one company, Dentsply Implants, knows that some things break, and they were brave enough to address the problem. And EV could stand for every variable, because what they found out is they said, oh, we'll fix a few things. They found out it was easier to just change everything. And there is a cause and effect to these problems, and they have a strong engineering background and a remarkable set of data. So they recognize that if you can address every variable but not change the essential values of the system, you'd be way ahead. And they wanted to make it evolutionary, not revolutionary, so hence EV. What's the same? The biological foundation, you've heard about it. We won't go through the details of microthreads and conical seal and biomanagement complex and osteospeed. We know all about it. And we know its value in terms of an aesthetic foundation. But what has changed? Well, the physical properties of the components are remarkably different. You've heard about 17% and 41% and 47% when we talk about the strength of the implant abutment interface and the strength of the uni abutments and the strength of the implant body itself. And the logistics have changed, and we'll talk about how some of these logistical changes create remarkable advantages for us right now today, and some remarkable advantages for us going forward in the next 6 to 12 months. Let's begin by considering the aesthetic foundation. We've grown up hearing about this implant system, and for people who come from split households in their practice, they'd say, oh yeah, Astra's a great implant when you really need an aesthetic solution. I use it in the anterior all the time. Well, I get that. And what we want to do is recognize that the key logistical evolution for the aesthetic foundation, since we've kept all the good stuff, is actually that this abutment now can only fit in one direction. So our prosthetic results are more predictable and therefore easier to accomplish. We maintain this aesthetic with osteospeed and good surface osteogenesis, transcortical osseous control with microthreads, the absence of implant abutment micromotion with a conical seal design, and bioarchitectural tissue control through a connective contour you've heard about over and over again. None of this changes. So this morning, what I thought I'd do is talk a little bit about the artistic, a little bit about the powerful, and a little bit about the many. Just 3 cases. And we'll try to identify things that are unique about the new system and how you might find advantage in using them. So when we think about single missing teeth in the anterior, we're really talking about a need for biologic superiority. What we're also thinking about in treating a 30-year-old patient is this question that I pose to each of you: how many of you have treated a 40-year-old dental implant? And this is a very important question, because this man will live to 70 years old, and I want to know that my implant restoration can follow him through his progression in life. And so we actually want to apply the very best prosthesis at the very best time. We plan carefully. We have our rules. We follow soft tissue contours in this, what Astra now calls a crown-down approach. We know where the zenith is, and now we can plan. We can keep the good stuff, if you will. Peri-implant tissue stability requires about 2 millimeters of soft tissue and bone facial to the implant. And soft tissue integration is going to occur optimally when the abutments have no micromotion and are made of titanium or zirconia. These are just rules we pass on every day. And so we think about this, and EV offers us this opportunity to have conical seal design without micromotion, a beautiful titanium temporary abutment. It actually is used in many cases as a definitive abutment, but the tie design in this system was available early. It makes a great temporary abutment. And we have the ability to make sure that we can maintain the hard and soft tissues around this restoration. Now, the implant placement is according to our 3-2 rules that we won't go through today, but the important part is to assess the architecture. The periodontal probe is always used first in surgery, and go through the process of extraction without ruining the bone around the implant, making sure that we have a good buccal plate of bone, and then evaluating, in fact, that we have the proper architecture. Affirming this, we can now plan and execute. We know that we need circumferential bone housing at the implant, that the bone, if it does have a dehiscence or furcation, can't be ignored, and the soft tissue dimensions will be revealed as we move forward. Now we want to preserve this all. AstraTech has some guidelines. They're very useful for the new implant system. But one of the first things I want to tell you is you are going to be amazed at how much 2.2 millimeters will make in your decision making. In this case, the individual actually has a very large tooth. When we measure it, the root is about 5.5 millimeters wide. It's about 12 millimeters long. He's a very large individual. And so in preparing for this case, because we did not have access to our Simplant software at the time, we brought forth both the gold 4.2 and the blue 4.8 implants. In his case, we decided that he would be best off with actually a rather large implant for the maxilla, a 4.8 implant. So the first thing we do is begin our palatal approach using the new pointed Lindemann-like drill, which is very useful as a guide drill, and then move forward with the twist drill. They're all white stripes, you see, the 1.9. And then the step drill EV 2.5, and then the step drill again, making this osteotomy reach 4.3 millimeters very, very quickly. So it's a 1-3-5 progression according to our chart. We grab our implant with the color-coded carrier. You've heard about the attributes of these carriers. And now the implant is delivered. Nothing really different, and things are actually a little bit simpler. So the implants are placed with primary stability. You've heard both Barry and Clark speak about the remarkable primary stability. Here in a socket, we're challenged by stability, so we're really not often challenged by the inability to place the implant to depth. The orientation of the implant relative to a restorative reference point must be achieved. So what's interesting about this is we now have the opportunity to place the implant in its orientation in a buccal-lingual direction by following the flat to the direct buccal, as you heard earlier today. And of course, we never want to engage the buccal plate of bone in an extraction socket. So this implant offers us a stronger, a stiffer, and if you will, a stabler type of interface. And what's nice about this is the 7-point connection that we see here, very nicely revealed in this case as the 7th point. And this is going to allow us to always create an Atlantis abutment where dead buccal is. And that's a huge advantage. So we begin with the end in mind, thinking about what the restoration should look like, knowing where things belong. And now we're going to choose an abutment. There are two types of abutments. We have one that has no anti-rotation. It's circular. They come in two flavors, the uni type, which is narrow, which I really prefer to use, and then larger diameters, as well as the new triangular, which is fixed in its orientation. It is anti-rotated. It's two pieces and could be used very nicely here. In this case, we're going to go forward, and we are going to actually get to an abutment solution. If you were using a rotational system, it would be a direct abutment. Here, because of the early point in development, a good solution for a temporary was actually this tie design abutment. So the tie design abutment is also rotational in its sense. It's fixed along these 6 points, and it has a secondary screw, which is, as you see, color-coded. And so we can put this assembly together and now select an abutment that meets our restorative needs, place the abutment with stability, making sure lacking any interference with neighboring bone, which is nice with the contour of this abutment, and do not displace the implant. Evidence of motion means to abort the immediate procedure. So, stealing a little bit from Dr. Seuss, today you have to recognize you've got green screw, blue screw, gold screw, new screw. And the good news is that they all tighten to 25 newtons centimeter, and as Clark said several times, they all achieve a preload of greater than 250 newtons centimeter, or newtons, which is very comforting for us today. One thing that I will tell you is that in an immediate or a transitional period of trying in an abutment, no one should decide to put these in at 25 newtons centimeter. Put them in at finger pressure before you decide this is the abutment you're going to use. These interfaces are made extremely well, and once they're tightened to 25 newtons centimeter, an immediate placed implant, taking out the abutment would be challenging without disrupting the placement of the implant. So, in this case, we do not want to be bumping into any adjacent teeth. The implant is not parallel with the crown, so we make a minor adjustment out of the amount with the provisional abutment. It's tightened at 15 newtons centimeter, and then we are going to orient the crown to the abutment, and then after it's picked up, organize this extraorally through refinement. And now we can start to think about getting this cemented in place. One of the advantages of a scalloped temporary abutment, of course, is it's easier to retrieve the cement, which must be done in all these circumstances. So we cement very carefully. We're cautious and highly suspicious that any cement would be left behind. And slowly but surely, we get to the point of completing the day's work by loving our soft tissue. The abutment must be cleaned and polished. The crown margin must be well adapted to the abutment. The crown must be highly polished, and for those of you in the surgical persuasions who want to be involved in provisionalization, if you do not have a lathe in your practice and you cannot highly polish this away from the dental chair, you need to invest in the proper equipment to manage this aspect of treatment well. Cementation is permissible only if residual cement is limited and removed, and it requires evaluation during the healing period, typically at 1 week and 4 weeks after this process has occurred. So we get our nice before and after situation and hope for the very best. Now, this patient goes home and heals. And if we're really ultra confident at the time of surgery, we could have indexed this, taken an impression, and actually be on our way making our Atlantis abutment. Or, as we did in this case, let this gentleman heal a period of 8 weeks, and he came back in, and then we got to the point of having to order the abutment. Many of you may be blind to this process. Many of you may not be involved in it. But if you have an impression and it ends up in the laboratory, they are going to choose an implant type. They're going to choose an implant, and there will be an EV solution here, and then choose all the other type of information in the spreadsheet, and finally you can get to ordering your implant according to your preferences. Here we are at 12 weeks, and we have nice soft tissue healing with a little blunting of the papilla, but very healthy, uninflamed tissues. And we just come back, simply unscrew this, and because of the orientation guaranteed by that 7th position, this synergy Clark spoke about, where 6 + 1 is much more than 7, I have to agree with you. These abutments fit extremely well without any caution or complication. The design is, as we're used to with Atlantis, referencing, of course, the importance of the soft tissue contours and the location of the implant in the virtual plan. Now, one thing I want to mention is you don't see Lyndon Cooper spend any time taking any extra effort to make any special impressions. And that is because the Atlantis system only knows where the implant is and where the soft tissue contour is. Everything created by the computer between that contour and the implant is a pure work of fiction. It's mathematical. And so all the effort everyone tells you on a podium about taking these very special adapted impressions with custom impression copings should be drawn into question if you're moving forward in this environment. Here is our Atlantis abutment. Notice we like to stay at the soft tissue crest lingually, only about 7.75 millimeters subcrestal on the facial. And as we've learned over the years, when we follow this 3-2 placement rule relative to the zenith, everything at 12 weeks is predictable in terms of soft tissue stability, and our abutment is in place. In this case, I'm sorry to go rapidly, we milled crown with a cutback from the library, sintered it, applied some transparent porcelains and some incisal porcelains, and the importance here is to show you that nothing in this system has changed regarding the importance of soft tissue architecture and osseous control, and that when we look at this 3 weeks after crown was placed, you see good soft tissue adaptation. This is the contour, coral pink stippled, knife edged at our implant. This is the natural tooth. And as we come across here, radiographically, supportive bone at the implant at the adjacent teeth, the contours of the abutment far exceeding what we would have on a stock abutment to support this with good access to cement and contour for our ceramic our crown. And the final restoration, a bit deficient in trying to match this gentleman's difficult translucency. We got a little bit carried away here, but that's an easy alternative for us. The important part is how we were able to manage the soft tissue contour from the beginning of therapy to the end. Complete preservation of architecture, which is the goal of implant therapy. What this has offered this individual is an implant with an improved interface in terms of the risk of screw loosening, screw fracture, abutment failure, and the promise that all the good things that we've published and published and published about, the preservation of soft tissue, the health of the peri-implant mucosa, the support of the bone, are not lost in this evolution. Let's talk about molars. EV's built to last. That's the title of my presentation. And the whole idea gets back to this notion of what are you going to do for an individual? Go home tonight and think, do I really know what a 40-year-old dental implant restoration looks like? That question raises tremendous fear and trepidation in my mind, and I hope it does in yours. And we will be fixing a lot of implants. And we want the next generation of implants to be more robust. So what we have with EV is an increased implant dimension everywhere across the line. We have increased strength of the implant, increased strength of the implant abutment interface, increased strength of the abutments and bridge screws, and of course, increased primary stability. Clark did a wonderful job in the previous presentation reporting on the data that the engineers created and Clark derived for the primary stability. I won't repeat that here. But how do you treat a missing molar? Well, when I look at a missing molar today, I have a laser-focused view of this part of my chart. This is the EV surgical tray. And the first thing I'm thinking about is, I want this to last a long time. Do I really have an opportunity to use this new 5.4 millimeter implant? Why is this important? We know more people are going to choose implants. And the reason this is so important is, look at the penetration and market for countries like Korea, Italy, Spain. And as you get to the US, this number is going to increase dramatically. This is a realization for our corporate partners, but it's the reality of our practice. When someone walks in your practice with a missing molar, they are going to choose an implant. And they are likely going to be under 40 years old if they have a single missing tooth. We know this from our clinical trials. And when you look at the effectiveness in terms of one dental implant, because the industry believes in dental implants last forever, they've argued that it doesn't cost so much in the long term. But if you have to keep replacing bridges, it gets very expensive. And when you finally lose an abutment and have to add an implant, it becomes very expensive. So the argument is that implants are cost effective. And I didn't want to bring the data, but I will let you know that there are two cost-utility analyses that have been published in 2013 and 2014 that argue that, with some comprehension, that the dental implant is long-term the cost-effective solution for the single missing tooth. That's data we never had before. Now, there's very little written about what patients feel about dental implants. And so Jim Thornton wrote the story of his dental implant experience in AARP. I do a rough amortization based on the best case life expectancy. My conclusion for myself is each tooth will cost me 17 to 19 cents per day, a relative pittance. Moreover, not getting the implant could have its own cost, especially if I continue on the ice cream and lard diet that has become my routine. I sign up for 4. This is really written. It's a great story. And this is a story we need to be telling our patients. But we have work to do. Because the other thing we have to tell the patients is, when you look at the data for 5-year cumulative survival rates, whole arch survival is above 90%, molar region is a little lower. And in this case, 47 of 114 implants, 41% of them in the posterior showed post-loading complications, including coronal fracture of a fixture and abutment screw loosening. I mean, this knowledge held within a corporate entity known as Dentsply Implant drove them to decide to take the brave step to be better, to quit ignoring the fact that we can afford to live with 0.1% implant fracture and a 3% screw fracture problem. They want to take it to 0. And here we go, 11 were removed due to coronal fracture of the fixture. So in the marketplace, you have lots of choices for single molar replacements: multiple narrow implants, existing wide platform implants, wide body implants, ultra wide body implants, and of course the newest entry is the OsseoSpeed EV 5.4, and I would argue that this is the rational approach. When you look at Ate's review of immediate placement, immediate restoration of single implants for molar teeth, he says it works fairly well. My argument is, most of our patients come to our practice with a single missing molar. They can wait 3 months. I'm not a big fan of this, but I do acknowledge the work that's been done and that it is successful. When you think about why you might not want to do an immediate therapy, all you have to do is look at Chris Hammerly's work, and in the alveolar ridge, it undergoes a mean horizontal reduction in width of 3.8 millimeters and a vertical reduction of about 1 millimeter within 6 months after tooth extraction. And in molar sites, they indicated a high need for soft and hard tissue augmentation. Interesting. We don't think about this in molar sites. And if you look at this work published in 2012, wide diameter implants were effective in reducing marginal bone loss in the first molar region. That's encouraging, but 3D FEA results showed that maintaining greater than 1.8 millimeters of buccal plate thickness was needed to achieve that result. So it draws into question a very important point. What role does an ultra-wide implant have in the marketplace today? It's very interesting. My perception is most alveolar ridges are going to undergo a resorption of 3.8 millimeters. So let's say you start with a ridge of 1.2. 3.8 is close to 4. We're all friends here. That's 8 millimeters of ridge left. Why do you want to use a 7 or 8 millimeter wide implant when the mechanical result says you need about 1.5 to 2 millimeters of bone, buccal, and lingual to it? Well, that's the point about being rational and letting science drive your decisions about what you need. Better is to consider an implant that fits in a residual alveolar ridge, but is strong as some of those ultra-wide implants. Hence, my excitement about EV 5.4. So this 5.4 millimeter implant may not, or perhaps it may, fit very well in the context of what we know about dental anatomy. The average molar is about 11 millimeters wide mesiodistally at the contact point, but at the cervical region, it's only 9 millimeter wide. And it has the same width in a buccolingual direction. So how does 5.4 equate to the 9 millimeter scenario? Actually, with a 7 millimeter abutment, it makes a lot of sense. And the reason it makes so much sense here, if I can go back a slide, is that we are accounting for the alveolar resorption that we now know is so well documented. And it provides us with a realistic crown supported by an implant in that resorbed ridge. You've heard about crown down. You might think about this as important for a single anterior tooth. I think it's much more important in the high load areas of the posterior maxilla and mandible. And so we know we've got this 9 millimeter dimension. We know we can use a stock abutment of 7 millimeters. It has a nice submucosal contour, and it can be related to the existing bone. And we can use that 5.4 millimeter implant that has this remarkably, as Clark said several times, robust interface. So when you talk to your colleagues, or you ask a patient who may have been on the web and has found these ultra-wide implants, it's time to teach a little biology. If you hear it's only 5.4 millimeters wide. Yes, the average molar crown is 9 millimeter wide as it exits the bone, not 11 or 13 millimeters. You can use a 7 millimeter or an 8 millimeter abutment, and this implant will support that abutment and retain that residual alveolar bone better, according to our data, than what else is available in the marketplace. How wide? Marco De Guidi did something very interesting. He addressed this question. He said smaller implant diameter, and these aren't small, 5.0 and 5.5, and shorter implant lengths correlated with a statistically lower crestal bone resorption. And Park said 8 millimeter implants showed the lowest survival rate, and as the diameter widened, the failure rate increased. He speculated that wide osteotomies might invade minimal space requirements so that you do not have 1 millimeter of bone buccolingual, and you don't have 3 millimeters between implants, and you're not 1.5 to 2 millimeters from the natural teeth. So I think if you're considering what the 5.4 offers you in the context of the marketplace, I would urge you to read the data and then go ask the people who are trying to sell you an ultra-wide implant what the rationale is, other than primary stability in an extraction socket. So I better show you something. Here's a patient. Going to lose a tooth over here. And without going through all the surgical details, we extracted the tooth, we let him heal. We came back and we placed a 5.4 millimeter implant in a healed ridge. And we placed a very simple 5.4 millimeter by 6 healing abutment. Done in a single stage surgery in a well-healed ridge. The period of time from extraction to implant placement was exactly 4 months, and the period of time healing here was extended exactly 4 more months for pragmatic reasons. So in placing this implant, there really was no question where it needed to be. Again, we did not have the opportunity to use EV implants in the planning software, so we avoided the use of Simplant, not something I'm comfortable with. This is the tray, and I said when I think about molars, I instantly think about 5.4 and what the solution will be. And now you have to start making decisions about how that implant can be placed. Clark showed you a chart where he showed you that his insertion torques for the maxilla were 24 newtons, and his insertion torque for the mandible were 45 newtons. It's in the posterior mandible where you're going to be surprised by how difficult it is to seat this EV implant. They get tighter than you might imagine. So we go through this process of making sure that we make the right choice between X and V. By using the V shape, I can extend the lateral walls of this implant just so that will creep down and get tight. If I need it to be even more loose and denser bone like type 2 bone, then I'd probably go to X. Anyways, we do our procedure. We have an implant and a healing abutment. We have an impression coping. Clark talked about all these. They are all color-coded. We have an analog. We place our abutment, and we can make our final restoration. Simplified impression. Being able to grab this with my finger and glove and just let this gently screw itself into place without worrying about orientation really makes a difference in these molar sites. This is as good a photograph as you can have of these 6, and the 7th being lingual here, spline, knowing that we will never have a problem getting this oriented. As I go forward, you've seen the animation, so I won't spend too much time, but again, it has to be placed with the screw and not with the body of the impression coping. I like the narrower impression copings. There are 2 designs you'll see as we move on because it gives me more space, and the impression material finds its way into the sulcus. And again, as it fits, it finds that 7th spline and times it. This is really a remarkable innovation. Now, I'm going to use a stock abutment that was all that was available. At the early time points, you can see how this fits into our plan. And now we're going to make a ceramic bonded to titanium crown using, instead of an inexpensive third-party tie base abutment, we're going to actually start using, in a very favored way, either a custom Atlantis titanium abutment or a prefabricated tie design abutment. So we've adjusted its height. We've scanned and milled an all-ceramic Emax crown. They fit very nicely onto the tie base or the titanium tie design abutments. The crown is then sintered. It is stained and glazed. And then it is assembled on the abutment using resin cement. So what we are doing is creating a screw-retained crown. And this is a very effective way to do this. So back to our patient, there's the abutment, and we have to go through the process of sealing this. And what we like to do is etch the Emax and monobond the Emax so that when we're going to seal this in the mouth, we take opaque resin and cover the titanium, and then take whatever color the tooth is and use composite to seal our single tooth crown. And so we can get to the point, here's the opaque resin about a 0.5 millimeter below the surface of our milled and stained and glazed crown, and now it simply disappears when I choose the proper colored composite material. So this disappearing act just takes minutes. You'll notice that even with the titanium stock abutment, we're able to create a crown-like contour. That 7 millimeters is approximating the 9 millimeter diameter. Easy access for hygiene and probing, and in this world of peri-implantitis, what else would you want? And so here is our tie design abutment with the cemented crown and the screw access for our screw retained crown on our 5.4 millimeter abutment. And the premolar bows in respect to our restoration. Don't have any other way to explain that one. This is within minutes of its delivery. There is very little blanching, the tissue moves, and you can see we've created a very nice lifelike contour for this all-ceramic restoration with a titanium substrate. Very, very simple, extremely inexpensive, and I think you'll see this as the future. Now, for those of you who think about the laboratory process here, recognize that if this were done with an Atlantis abutment, the core file comes back, and the laboratory can have actually milled that Emax crown or a zirconia crown before they receive the next day their abutment. So it's a matter of simply applying this and moving very rapidly in the workplace. Workflow wins in the digital environment, and I think this system is set up for a remarkable future. So my evolution has been from 5.4 or 4.5 millimeter implants to the 5.0 and now to this 5.4 millimeter implant. I want to spend the rest of my time talking about my favorite patient, and those are those with the edentulous arch. These patients really need special care. They often spend their last pennies to have their teeth replaced with implants. This is a common example of what we see in the University of North Carolina. And you know, human equals diversity, and so our patients come in different sizes and shapes, and why should we compromise on a treatment plan? We all know about the rapid proliferation of the notion of one treatment plan for the edentulous patient. It's been popularized. But today, we should find the fit instead of make it fit. And when we have 3.0 to 5.4 millimeter implants, and the 3.6 to 5.4 varieties all come in 6 millimeter heights, we can begin to think about rational plans for every individual. And that gives us a breadth of information that remains to be explored. So the big problem here is actually complications with edentulous implant prosthesis. This is just one example of the proliferation of screw fracture and abutment screw loosening. Our patients can't afford this, and nor should they expect it. So what we're looking for are better solutions, and the new uni abutment, as Clark described, begins at the top with this enormous bridge screw and preserving the 11-degree conus interface and an improved internal fit. There's a uniform platform angle of 33 degrees, and it facilitates what I would consider to be an absurd 66-degree off-angle placement. Now, what's interesting is there's one 33-degree platform shared amongst the 3.6, the 4.2, the 4.8, and the 5.4 implants. That's important to remember. So back to our patient. First thing is to make sure that you prepare for implant placement with the proper alveolectomy for restorative dimension. This takes some time and effort. And then just look at the tray. We're going to use a 4.2 by 11 millimeter implant in 4 positions, and we know to follow the prescribed methodology. And so we begin with the twist drill EV through the guide and then completing the osteotomy, moving to the step drill EV with our parallelism or position indicators. This is the first 2.5 to 3.1, and then moving to the 3.1 to the 3.7. This would be the terminal drill sometimes for a 4.2 millimeter implant, but now we have to make an apical decision. Can we place this implant in the dense parasymphyseal mandibular bone without moving to a V or an X? And in this case, I chose to use the V, which removes the step while keeping the lateral walls the same. The X expands everything a little bit, as I understand it. So you have to make an apical decision. You also often have cortical decisions, and here you have to choose to expand this 3.7 to 3.9 or to 4.2 for a passive fit. And oftentimes you'll find that the 4.2 in very dense bone is necessary, as you see here. So every implant has its own driver. They're color-coded. It's not hard to figure out how to use this, but the packaging is very simple because I can flip the lid off with my thumb as I'm holding it in a case, and that's comforting, so no implants drops out of an open container before it gets to my gloved hand. I place this with a firm pressure and lift this out, and now I can place my implant. Even with this, you'll see that the implant has a little bone on it because we actually had to back this out and go back again, not with the V, but with the X, because that distance was as far as that went before it stopped at its 45 Newton centimeters. This thing wants to be automatic. I don't know why. In any event, we've talked about the uni abutments and how they work, and so the uni abutments are placed. Sometimes angles will require you use an angle component. They exist in this system, and we go through the conversion prosthesis, which is not our point of the discussion today. And finishing the conversion prosthesis, we get 2 months later, and here are the impression copings for the uni abutments. They look, for all intents and purposes, like the others. Clark mentioned liking to fit the uni abutments with these as drivers. I concur, it's simple. And the final impression is poured as a cast with a removable soft tissue moulage, so the abutment interface can be scanned. And then we're going to have Atlantis make these wonderful prostheses for us, these nice ISIS bars that we've grown up with over the last few years. They fit remarkably. And again, you find this on your web order. You get to the point where it says abutment or ISIS. You hit ISIS, you choose what you would like, and you start making your decisions. And lo and behold, they return in a box about 5 days later, this wonderful prosthesis. So we do our tooth arrangement and try-in. We flask, we opaque, we process. And now it gets fun because we're going to get to the point of delivery. Okay? And as we get to the point of delivery, remember what I said about this big screw. The confidence in setting this bridge on 4 uni abutments with these 1/8 millimeter screws is remarkable. And at the end of the day, these are screwed in, finger pressure, covered with composite and closed, and we have a very, very happy patient. This is what this looks like. Angled implants. Again, without having the access to Simplant, we are a little less oblique in our planning than we would be with the confidence to go forward. And I just want to show you what we're talking about. This is a competitor screw used commonly in the all-on-4 technique. This is the old Astra bridge screw, and this is this behemoth that we are going to learn to love and use on a regular basis. We take a lot of records and measure oral health quality of life, but I want to show you what we do for patients. She knows we use her photographs. This is the day we met her. This is the day she was converted. And this was last week when she got her bridge. She danced like a butterfly out of our office. Remarkable, happy lady. So this is my favorite treatment. I could do this all day long. Did I mention the big screw? I think this tells the whole story. When you start redesigning a system for the ground up, you have remarkable latitude, and they optimized and magnified everything they could. And this is a really important part about my love for the uni abutment and my continued enthusiasm for this type of treatment. So it's about who, and I think what EV represents is recognition that we were failing hundreds of patients, and today, going forward, who will still exist, but they will be far fewer in number. With that, I know I've run a few minutes late. I do want to thank Dr. Paquette for her kind patience and every one of you for your kind attention. Ladies and gentlemen, enjoy the AO meeting.